Imagine struggling to breathe, your lungs stiff and unable to absorb the oxygen your body desperately needs. This is the reality for individuals battling acute respiratory distress syndrome, or ARDS. In this video, we'll delve into the complexities of ARDS, exploring its causes, how it affects the body, and the approaches used to manage this life-threatening condition. ARDS doesn't discriminate. It can arise from a variety of triggers. The most common culprits include severe infections like pneumonia or sepsis, where the body's overwhelming response damages the lungs. Trauma, such as a car accident or a fall leading to significant injuries, can also initiate ARDS. Other causes include aspiration of stomach contents, pancreatitis, drug overdose, and even near drowning. Essentially, any condition that causes widespread inflammation in the body can potentially lead to the development of ARDS. At its core, ARDS is a disease of inflammation. Think of your lungs as tiny air sacs called alveoli surrounded by delicate blood vessels. Normally, oxygen passes easily from the alveoli into the blood. In ARDS, however, inflammatory chemicals flood the lungs, damaging the lining of the alveoli and capillaries. This damage increases permeability, allowing fluid and protein to leak into the alveoli. This fluid accumulation, known as pulmonary edema, impairs gas exchange. The alveoli collapse, become stiff, and are unable to properly transfer oxygen into the bloodstream, leading to a dangerously low blood oxygen level, a condition called hypoxemia. In short, ARDS disrupts the lungs' ability to perform their primary function, to oxygenate the blood and remove carbon dioxide. ARDS is a significant public health concern, affecting hundreds of thousands of people worldwide each year. It often occurs in critically ill patients already hospitalized for other conditions. While it can affect people of all ages, it's more prevalent in those with pre-existing medical conditions, the elderly, and those with compromised immune systems. Accurate figures on the incidence of ARDS are difficult to obtain, as it often goes underdiagnosed or misdiagnosed. However, it's estimated that ARDS affects a significant percentage of patients admitted to intensive care units. The symptoms of ARDS can develop rapidly, typically within 24 to 72 hours of the initial injury or illness. The hallmark symptom is severe shortness of breath, or dyspnea. Patients may also experience rapid breathing, called tachypnea, and a persistent cough. As the condition worsens, the skin may appear bluish, a sign of cyanosis, indicating low oxygen levels in the blood. Mental confusion and fatigue can also occur due to oxygen deprivation of the brain. In severe cases, ARDS can lead to respiratory failure, requiring mechanical ventilation. Diagnosing ARDS requires a combination of clinical assessment and diagnostic testing. Doctors will carefully evaluate the patient's symptoms, medical history, and potential risk factors. A chest X-ray is crucial to visualize the lungs and identify characteristic features of ARDS, such as widespread opacities or whiteout appearance caused by fluid accumulation. Arterial blood gas analysis measures the oxygen and carbon dioxide levels in the blood, providing objective evidence of impaired gas exchange. Ruling out other conditions that can mimic ARDS, such as heart failure, is also essential. The Berlin definition is a widely accepted set of criteria used to define ARDS based on the severity of hypoxemia, the timing of symptom onset, and the presence of bilateral infiltrates on chest imaging. ARDS is often classified into mild, moderate, and severe based on the P2O/FeO ratio, which reflects the level of oxygen in the blood relative to the amount of oxygen being supplied. A P2O/FeO ratio of 203 indicates mild ARDS, 102 mg indicates moderate ARDS, and less than 100 mg indicates severe ARDS. This classification helps guide treatment strategies and predict patient outcomes. The treatment of ARDS is primarily supportive, focusing on improving oxygenation and reducing lung injury. Mechanical ventilation is often necessary to provide adequate oxygen to the body and allow the lungs to rest and heal. Strategies such as low tidal volume ventilation and prone positioning, placing the patient face down, can help improve oxygenation and reduce ventilator-induced lung injury. Fluid management is crucial to prevent further fluid accumulation in the lungs. Medications, such as antibiotics to treat underlying infections and sometimes corticosteroids to reduce inflammation, may also be used. Nutritional support is essential to provide the body with the energy it needs to recover. Ultimately, the goal is to address the underlying cause of ARDS while supporting lung function until the lungs can heal. Preventing ARDS primarily involves preventing the conditions that can lead to it. Prompt treatment of infections, especially pneumonia and sepsis, is critical. Taking precautions to avoid aspiration, such as proper positioning for patients with swallowing difficulties, can help. Avoiding excessive alcohol consumption and drug overdose can also reduce the risk of ARDS. For trauma patients, early and aggressive resuscitation can help minimize lung injury. The prognosis of ARDS varies depending on the severity of the condition, the underlying cause, and the patient's overall health. ARDS can have a high mortality rate, particularly in severe cases. However, advances in critical care medicine have improved survival rates in recent years. Long-term complications of ARDS can include chronic lung problems, such as pulmonary fibrosis, as well as cognitive and psychological impairments. Research continues to focus on identifying biomarkers that can predict the development and severity of ARDS, as well as developing new therapies to reduce lung injury and improve patient outcomes. Some recent research is exploring the use of stem cell therapy and targeted drug delivery to repair damaged lung tissue and reduce inflammation in ARDS.